Thank you. So, today's topic is infectious disease part 4, understanding the transmission, prevention, and control of common respiratory viruses. As you people already know me, I'm Dr. Omer Khan. I'm a resident orthopedic surgeon doing my practice here in Rawalpindi Medical University, a major medical university here in Pakistan. So the learning objectives for today's class are, as usual, introduction, basic definitions, common respiratory virus in humans. We will discuss then etiology and epidemiology of viral respiratory infections will be discussed. Then pathophysiology of a viral respiratory infection. We will take an example of a viral respiratory infection and discuss the pathophysiology of how our body gets affected with any kind of viral respiratory infection and what is the cytokine storm and what are the inflammatory markers which actually damage our bodies. And what happened with COVID patients, we will discuss these things as well, that how the COVID patients used to die or used to succumb to the infection of the COVID-19 by looking at this example. Then clinical signs and symptoms of upper respiratory tract infection and lower respiratory tract infections. Then diagnosing a patient with viral RTI. How do you diagnose it? How do you come to know that what kind of virus it might be on the clinical picture, and then upon special testings, then management of patients with viral RTI, and then prevention strategies from getting viral RTIs. How do you prevent yourself getting infected with viral respiratory infections? So respiratory viruses are the most frequent causative agents of disease in humans. They are the most frequent causative agent of disease in humans with significant impact on morbidity and mortality worldwide. Common respiratory agents for several virus families are well adapted to efficient person-to-person transmission and circulate in a global scale. So most of the respiratory agents in the viral families are well adapted to efficient person-to-person transmission. They transmit from one person to another person with so efficiency that even if you sit with someone who is infected for 2 minutes or 3 minutes, you are you are prone to get infected with the virus that person is carrying. Community-based studies conducted over the past 5 decades or so confirm that these viruses are the predominant causative agents of acute respiratory infections. So basically, in the past 5 decades, there has been extensive research which showed that viral respiratory infections are more common than bacterial respiratory infections, and they are by far the predominant causative agents of acute respiratory infections. The respiratory viruses that most commonly circulate in all continents as endemic or epidemic agents are influenza virus, respiratory syncytial virus, parainfluenza virus, metapneumovirus, rhinovirus, coronavirus, adenovirus, and bocaviruses, etc. So this thing is also important. Approximately one-fifth of all childhood deaths, 20 out of every 100 worldwide, are related to acute respiratory infections, particularly in impoverished where ARI case to fatality ratio can be remarkably higher than populations of tropical regions in temperate regions of the world. So basically, if you look at the global scale, approximately one-fifth of all childhood deaths, that is a lot. 20 out of every 100 worldwide are related to acute respiratory infections, and that is a lot. So this illness of respiratory system by viruses kills a lot of children, kills a lot of infants, kills a lot of toddlers. This is a preventable disease. This is an infectious disease which can be easily overcome, which can be easily controlled with good diets, with good hygienes, etc. But still, up until this point, approximately one-fifth of all childhood deaths worldwide are caused by viral respiratory infections, or even you can say viral respiratory infections with complications, because many of the times if the viral respiratory infection prolongs, then there are secondary bacterial infections as well. So then we call it acute respiratory infection, whether it was viral initially, but then it became secondary bacterial infection as well. But still, most of the time, the infection starts with some virus, and when the person gets uh, sick, there is secondary bacterial invasion as well. So, basic definitions for a better understanding. Upper respiratory tract infection. What is URTI? URTI means the infection of upper airway starting from nasal cavity, nasopharynx, oropharynx, and larynx. So, basically, the infection above vocal cords is called upper respiratory tract infection. Then LRTIs are lower respiratory tract infections. LRTI means the infection of lower airways starting from below the vocal cords, including trachea, bronchioli, and the lowermost level of alveoli. Then what is RT-PCR? RT-PCR is basically reverse transcription polymerase chain reaction, and it is a molecular diagnostic method used to detect RNA viruses. It is the most advanced form of clinical testing. They used to test coronavirus swab tests as well. Whenever they used to take swabs from our nasopharynx or our nasal cavity, they used to perform these PCR reactions, these PCR chain reactions, which would detect whether a person has SARS-CoV-19 or not. So it is a molecular diagnostics test, a very rapid diagnostics test used to detect RNA viruses like RSV, coronavirus, rhinovirus, etc. Then reverse transcription. What is reverse transcription? The viral RNA is converted into complementary DNA using an enzyme called reverse transcriptase, and then a reaction called polymerase chain reaction, in which the complementary DNA is amplified, which is copied many times using specific primers. So even tiny amounts of viral genetic material that we have taken from a nasopharyngeal swab or any kind of testing method, if there is tiny amounts of viral genetic material, it becomes detectable after a PCR test. Understanding the respiratory viruses and infections. In, in this section, we will discuss all the clinical details regarding the basic understanding of respiratory infections and viruses. So, most common respiratory viruses in humans. This table shows most common respiratory viruses in human beings, and it is uh, human respiratory syncytial virus, human parainfluenza virus, human rhinovirus, adenovirus, human coronavirus, and then SARS-CoV-19 one type, then human metapneumovirus, human Boca So all of these viruses which cause most of the time infections in human beings, they have been listed in this table. So, human respiratory syncytial virus has two groups, group A and group B, and they most commonly cause upper respiratory tract infection, URTI, or bronchiolitis, or croup, or bronchitis, or pneumonia. And similar to that, human parainfluenza virus also causes upper respiratory tract infection, croup, bronchiolitis, bronchitis, pneumonia. So basically, many of these viruses not only cause upper respiratory tract infections, but they also cause lower respiratory tract infections as well. Human rhinoviruses most commonly cause upper respiratory tract infections, but they can also cause asthma and COPD exacerbations as well. Then adenovirus, uh, human coronavirus, these viruses also cause pneumonia as well as upper respiratory tract infections, and virus detection methods. We will discuss these detection methods later on in the diagnosing section, but many of the time there are cultures or real-time PCRs or antigen detection methods used as well. So basically, These viruses can be easily detected using PCRs or cultures, and it is very evident to know which kind of virus is using different lab reagents. So, etiology, modes of transmission, and risk factors of respiratory viruses. So, influenza viruses have four types: A, B, C, and D, and all of these influenza viruses transmit from one person to another person through respiratory droplets. For example, if you're sitting with a person and that person sneezes right on your face without covering their nose, and all of the droplets that the person sneezed out into the environment, if the person is infected with influenza or parainfluenza or respiratory syncytial virus, that sneezing respiratory droplets are able to transmit virus in all of the people sitting right next to that person. That is why if a person is sick and is sitting indoors with enclosed rooms or enclosed spaces with other people are bound to get infected because these viruses mostly spread via respiratory droplets. You sneeze, you cough, and you are shedding virus everywhere. So risk factors are close contact, crowded environments such as schools, hospitals, military, and seasonal load of the virus in the environment as well. And that is why these viruses are most active in winters because our respiratory membranes become dry and become weak in the winter season. So we are more prone to develop infections in winter season than in summer season. Similarly, respiratory syncytial virus, parainfluenza virus, rhinovirus, adenovirus, coronavirus, bocavirus, most of these viruses spread through respiratory droplets, person to person contacts. Some are also spread via direct contact as well, such as rhinovirus, because if you touch your nose, you are having viral rhinitis. Rhinitis means inflammation of the nasal cavity. Nasal cavity inflammation is called rhinitis, and the rhinovirus is the most common cause of flu, which only affects nasal cavity. If you are not having any kinds of sore throat symptoms and you're only having running nose, then most probably you are infected with rhinovirus. And this virus spreads in the environment through direct contact. And if you touch a person's face or if you touch a person's secretions and then you touch your own body, then you are uh, infected with the rhinovirus immediately. Then adenovirus, coronavirus, bocavirus, all of these viruses are transmitted through respiratory droplets or direct person-to-person contact. But there are some other examples as well, such as coronavirus, which are also transmitted to human beings via zoonotic spillover. What is zoonotic spillover? So zoonotic spillover is uh, transmission of a virus from one species to another species, such as monkeys, bats, or camels. They are usually infected with coronavirus, but their coronaviruses usually do not infect human beings. But if some coronavirus uh, mm, uh, at the same time infects camels and then it transfers itself onto the human beings as well, that is called zoonotic spillover, means the spillover from some other animal species to the human beings. So coronavirus has a remarkable ability to do the zoonotic spillover, and that zoonotic spillover happened in China in 2019, and the pandemic happened because the coronavirus of the animals started infecting human beings, and we were not ready for that virus. Our immune systems were not ready for that virus, but now all of the world has become immune to this virus because almost all of the persons in the world have been in contact with this virus now. So household contacts, healthcare exposure, or travel to endemic areas is also important in risk factors for coronavirus. So, epidemiology of respiratory viruses. Acute respiratory infections are the most common illnesses in all individuals, regardless of age or gender. Yeah, most common illness in all individuals, regardless of age or gender, is respiratory tract infection because we are inhaling air every minute, every second, and we are prone to develop any kind of respiratory infection because we are continuously inhaling the air in our environment. So if the air is bad, we are bringing bad air into our lungs and our upper respiratory pathways. And if the air is good, we're bringing good air into our upper respiratory or lower respiratory pathways. Nearly 4 million people die every year owing to respiratory illnesses worldwide. Complication rates and mortality rates are most common in underdeveloped and developing countries, especially in lower socioeconomic households. Secondary bacterial infections are also known to complicate the viral respiratory infections worldwide. So, what is a secondary bacterial infection? It's just like you're having flu, but it is purely a viral infection and your body is fighting with it. But at day 3 or day 4, you you start having worsening of the symptoms, and there is pus discharge, or there is acute fever spike, or the worsening of the symptoms occurs and you are having more fever and more severity of illness on day 4. Then there is high chance that the bacteria which were not able to affect your mucosal surfaces or upper respiratory linings previously are now attacking your body as well because they have got the chance. Because of the weakened mucosa or weakened respiratory epithelium, now bacteria have got the chance to infect you. So previously bacteria were not able to infect you, but now you have been infected with some virus. It has weakened your immunity of the respiratory pathways, and now bacteria have infected. So worsening of the symptom happens. And secondary bacterial infections complicate the viral respiratory infections worldwide. So, if you look at the epidemiology of respiratory viruses, I could not go into extensive details because if we start going into extensive details of every virus's epidemiology, then this lecture would become so long that it would be impossible to cover it in a single class. So, influenza virus A, B, C, and D. So the epidemiology of these viruses, they usually cause seasonal epidemics and pandemics. They have global distribution, high mutation rates, affect all ages, but severe in elderly, children, and immunocompromised. So influenza virus affects all ages, and most of the time, the severity of the illness is not that much. You mostly get recovered within 5 days or maximum at max 7 days. But in extreme age groups such as elderly people or young children or immunocompromised people such as diabetics or any other immunocompromised state of the person such as HIV, prostate patients, so these routine infections may become life-threatening in such conditions. Otherwise, you usually get infected with any kind of these respiratory viruses and you come out of it within 7 to 10 days, most of the times, late to late 7 to 10 days. But if you are having any comorbid condition, if you're an elderly person or if you're a young child, then there are chances that you may get severe infection or severe disease. Then similarly, respiratory syncytial virus, major cause of bronchiolitis and pneumonia in infants less than 2 years of age. Yeah, RSV is very, very common in less than 2 years of age. It causes bronchiolitis and pneumonia. And with secondary bacterial infections, many of the times the kids succumb to these infections and they die in their infancy or their toddler phase, early toddler phase. That is why protection of the kids from these viruses is extremely important, especially during the winter season. Reinfection common throughout life. Global pediatric burden is too much. It is not epidemic, it is a pandemic virus. So it is globally distributed. It has also some strains, RSV1, RSV2, etc. But the thing to remember is the major cause of bronchiolitis and viral pneumonia in infants less than 2 years, respiratory syncytial virus. Then human parainfluenza virus, HPIV 1 to 4, it causes croup. Croup is basically barking cough in children. So it causes croup, bronchiolitis, pneumonia. Outbreaks in young children are very common. Seasonal peaks are in autumn, fall, or winter season. Reinfections with this virus are also common because this virus has many serotypes, but it causes croup, which is laryngotracheobronchitis. I will show you the pictorial diagram. What is laryngotracheobronchitis, which causes barking cough in children? And then human metapneumovirus. It is also globally distributed, affects children, elderly, immunocompromised, and serum epidemic. It is not that much common. The first three viruses, influenza, respiratory syncytial, and parainfluenza, are very common. HMPV is not very common. Then rhinovirus, it is also one of the most common viruses. It's most common cause of common cold. It had more than 100 serotypes. So one of the most common causes of common cold in any age group is rhinovirus. It has more than 100 serotypes. It has year-round circulation. It does not peak in winter. It can cause infections even in summer as well. So many of the time when you have infections in winter as well as summer, so then you are most probably infected with rhinovirus. But the one good thing with rhinovirus is rhinovirus does not cause infections of the lower respiratory tract infections. So basically, it only affects the upper respiratory tract. It does not affect the lower respiratory tract. So that is the differentiating point of rhinovirus than other viruses, because the most common symptoms of rhinovirus infection are rhinitis or a little bit of nasopharyngeal irritation. It does not cause lower respiratory tract infection. Then adenovirus. Adenovirus causes pharyngitis, conjunctivitis. Conjunctivitis is basically inflammation of the eyes. Then pneumonia, it also has year-round outbreaks. So you often see outbreaks of conjunctivitis in your communities. There are times when people start coming to the ophthalmologists, eye surgeons, or eye specialists with a lot of conjunctivitis cases. There are a lot of people with conjunctivitis. So adenovirus is the cause of these outbreaks. Then coronavirus, seasonal COVID-19 cause a mild upper respiratory tract infection. Then SARS or MERS or SARS-CoV-19 2019 cause epidemics, pandemics with a high global burden. So coronaviruses are there are many types, but there are some very common types, and some are life-threatening types, such as SARS, which occurred in 2002 to 2004, then MERS, which occurred in 2012, and then SARS-CoV-19 2 occurred in 2019 and caused worldwide deaths. Then Bocavirus was identified in 2005. It causes respiratory tract infection in children. Global distribution, significant role in co-infections. So global versus Indian burden of respiratory viral infection. So there was a study conducted in 2021 or 2020, which showed that what kind of viruses are common in communities. So if you look at the word pie chart, if you look at the pie chart corresponding to the distribution of the viral infections in whole of the world, then you can see that rhinovirus is number one. Rhinovirus causes more than 35% of upper respiratory tract infections, viral upper respiratory tract infections worldwide, followed by influenza, or respiratory syncytial virus, which is 26%. But if you look at Indo-Pak or India, then you come to know that 29% of the infections are caused by respiratory syncytial virus, and then influenza A, influenza B, etc., are also common, but the rhinovirus is less common in our Southeast Asia than other parts of the world. So if you look at the picture of the world, then rhinoviruses followed by RSV are most common causes of upper respiratory tract infection, but in India or in Southeast Asia, respiratory syncytial virus causes 29% of the reactions, and then influenza A and influenza B cause 16 and 13%, or something like 27 or 28% of the infection. But the global burden of influenza is less, but rhinovirus global burden is great. So now we move towards the pathophysiology of respiratory tract infections. I took RSV example, the respiratory syncytial virus infection example for better understanding. It is the pathophysiology part is somewhat complex part. It is difficult to understand for people who do not have basic grip of immunology or virology or microbiology or molecular genetics, but I will try to simplify it as much as possible. So, RSV interciliated airway epithelial cells, AECs, are basically airway epithelial cells. So, what happens when a virus such as respiratory syncytial virus enters our airways? So, RSV interciliated AECs by binding to receptors on the surface of the cells, which are CXR3, CR1, followed by internalization of the viral particle into the cytoplasm. Following infection, intracellular pattern recognition protein receptors such as RIG1 or TLR3 sense viral single-stranded RNA or double-stranded RNA intermediates, resulting in the activation of transcription factors like NKB or IRF3. So if you look at this diagram, then number one is binding of the virus. If you look at the lower section of the diagram, which is an enhanced segment of the diagram showing inside part of the cell, the step one is binding. The virus is using its surface receptors proteins, which bind to the human surface receptor proteins, and then virus shows itself as some internal part of our body and fools our respiratory epithelial cells, and then it enters our respiratory epithelial cells by fusion, and then there is sensing by PRRs. So pattern recognition receptors are present in all of our body cells. These pattern recognition receptors then activate a pathway which uh, cause production of transcription factors like NKKB or IRF3. The nuclear translocation of transcription factors leads to the expression of several antiviral mediators. So these NKKB or IRF3 transcription factors then move into our nucleus, and they immediately start the reaction against the virus, because they have sensed it that what has entered the cell is not some body part, but it is a foreign virus, and these transcription factors then start expression of type 1 interferons, and antiviral mediators are produced in the nucleus, and these antiviral mediators and type 1 interferons then uh, start producing at larger scales, and they cause all of these cytokine storm, and they cause all of our symptoms. So we start having fever spikes, we start having runny nose, we start having cough. Cough is basically a protective mechanism. Cough Coughing is our respiratory symptoms protective mechanism. Our respiratory symptom starts coughing to eliminate the virus, because when we cough, we explosively jet out the air from our lungs. So basically, viral burden is moved away from the lungs to the outside environment. So all of these pro-inflammatory cytokines or chemokines start getting secreted from the nucleus, and they start flooding our bloodstream. So nuclear translocation of transcription factor leads to the expression of several antiviral mediators such as cytokines, chemokines, receptor for antigen presentation cells. RAG1 is basically retinoic acid inducible protein 1. TLR3 is basically toll-like receptor R3. IRF3 is basically interferon regulatory factor 3, and IFN is basically interferon itself. TNF alpha is tumor necrosis factor alpha. IL is written for interleukins. Interleukins are also chemokines. These are pro-inflammatory cytokines, and they start the process of inflammation in our body when we get infected with virus. And MSC1 is basically major histocompatibility complex 1. Then what happens? We are infected, and our immune system starts overreacting. Why am I using the term overreacting? Because our immune cells, all of the types of immune cells, start getting active by these viruses. So what happens? Airway epithelial cells and dendritic cells. Dendritic cells are basically tissue macrophages, detect viruses via endosomal and cytoplasmic sensors such as retinoic acid inducible protein 1 RAG1. Protein, basically G is for globulin. Globulin is a type of protein. So RAG1 that is retinoic acid inducible globulin 1. So retinoic acid means vitamin A. So vitamin A is very, very important for the respiratory symptom immunity, because vitamin A protects us from many of the severity of viral infections. So innate detection methods are used. Airway epithelial cells and dendritic cells um, uh, eat up the virus, and they break the virus, and they start signaling throughout our respiratory symptom that there is a virus, and all of these cells start getting active, because once alveolar macrophage or any kind of macrophage gets activated, it starts activating other cells as well. So if you look at the diagram, there are many pathways which are interconnected, and one cell type activates other cell type, and another cell type activates other cell type. So there is a cytokine storm in any kind of viral infection. So macrophages are getting activated via some other pathway. For example, a respiratory epithelial cell has has been infected with a virus. It produces type 1 interferon. Then this type 1 interferon uh, and some other interleukin, etc., such as interleukin 1, interleukin 25, interleukin 18, then activate alveolar macrophages and fibroblasts. When these alveolar macrophages and fibroblasts produce their own chemokines and interleukins, such as TNF, such as CCL2, such as interleukin 12, interleukin 6, interleukin 1B, etc. There are many. So in turn, they start activating other cells as well, such as dendritic cells. If you look at the dendritic cells, we see it produces TNF, it produces CCL, it produces interleukin 18 and interleukin 33. And these interleukins and all of these chemokines then activate natural killer cells, innate lymphoid cells, and then these innate lymphoid cells produce IL-13. And this IL-13 then activates eosinophils and neutrophils, and then antigen presenting cells also come away. So there is adaptive immune response against a viral infection. So our body is trying to control the viral infection so the lung damage gets controlled. But sometimes all of this turns into a vicious cycle of cytokine or chemokine storm. And this chemokine or cytokine storms is useful for the protection from virus, but then all of these reactive chemokines start damaging the respiratory epithelial cells as well. So there is amplification, then effector cell recruitment. These signals recruit natural killer cells, neutrophils, and activate macrophages, YTGF beta, tumor growth factor beta. Then adaptive immunity Dendritic cells mature and present antigens activating T cells and B cells. These T cells and natural killer cells will produce IL-17, interferon gamma, and granzyme B to kill infected cells. And as these infected cells start getting killed, and if the viral infection is too much, then our own natural killer cells and our own T cells start killing the respiratory epithelium cells because they think this cell is also infected, this cell is also infected, this cell is also infected. Kill all of these epithelial cells. So what happens? Our own immune response starts killing our respiratory epithelial cells. Outcome: if the response is balanced, it clears the infection. But if excessive cytokine or chemokine production occurs, then there is uncontrolled inflammation called cytokine storm. This causes tissue damage and all of the symptoms of the disease. So this used to happen in all of the patients who succumbed to coronavirus infection. If there was a balanced response in our body, we used to come out of coronavirus infection. But if there was a cytokine storm, we needed extra help in coming out of this storm and coming out of this tissue damage and disease prospect. And this overview of immunopathogenic response mediated by innate and adaptive immune cells during RSV infection. So I'm using an RSV example because a respiratory syncytial virus causes deaths worldwide, globally, and it has no subsiding phase because it keeps getting it keeps getting stronger and stronger, and it keeps killing our children. Changes in the innate and adaptive immune response can be a consequence of microenvironmental changes, genetic predisposition, or interaction with the virus. RSV can directly infect a variety of immune cells or indirectly alter their immune response. Example given by the secretion of soluble G, phenotype changes in immune cells, or the excessive secretions of immunosuppressive or pro-inflammatory cytokines, thus causing lung damage of infected person. So if you look at this virus, it directly activates monocytes, natural killer cells, macrophages, eosinophils, neutrophils, regulatory B cells, CD8 killer cells, CD4 helper T lymphocytes, dendritic cells, regulatory T cells, memory T cells. So one single virus can activate all of the police system of our body. And if our body responds in a balanced fashion, we usually come out of the infection. But if there is loss of balance and our body goes into a hyperdrive or overdrive, then this response is called immunopathogenic response because our own immune system starts damaging our own body in the name of clearing the virus. It's just like uh, a burglar or a decoy is held up in a bank and using people as human shields, and we, instead of getting that mm, um, armed person or armed robber, we start firing all around, and we start to kill every person who is being held as a hostage by that robber. So what happens that even if we kill the robbers, we are killing the hostages as well. For example, there are 10 robbers holding 100 hostages, and we go all in not in a balanced way, but in an excessive force. We use excessive force. What happens? We kill all 10 robbers, but then in the meantime we may kill all 100 hostages which were held by the robbers as well. So that happens if there is a chemokine storm or immunopathogenic response which causes the lung damage as well. So this was pathophysiology simplified, although this is not that much simplified. There were many aspects of this which I had to cover in simplicity because this is a molecular level biology and it becomes somewhat difficult for a person who is not interested in molecular biology. So, clinical signs and symptoms of viral respiratory infections in young kids. So, respiratory virus may affect both the upper respiratory tract and the vocal cords and above and lower respiratory tract below the vocal cords. Some viruses that affect the nose and throat can progress to the serious lung infections such as pneumonia as well. So there are some viruses we already discussed that they only affect the upper respiratory tract infections, upper respiratory tract, and there are some viruses which affect the lower respiratory tract, and there are some viruses which at the same time affect upper respiratory as well as lower respiratory pathways. So some viruses that affect the nose and throat can progress to cause serious lung infections such as pneumonia as well. Pneumonia is basically the infection of the lung parenchyma including alveoli. Some common signs and symptoms present in symptoms and toddlers presenting in symptoms and infants and toddlers are given, such as bronchiolitis, pneumonia, rhinitis, pharyngitis, apnea, vomiting, laryngotracheitis, febrile illness, dehydration, hypoxemia. So if there is inflammation of the bronchioles, then it is called bronchiolitis. If there is inflammation of the lung parenchyma and at the alveolar level, there is infection has reached, then there is pneumonia. If there is only nasal cavity involved, it is called rhinitis. If there is only throat involved or pharynx involved, it is called pharyngitis. If there is cessation of breathing due to this viral infection, it is called apnea. If there is too much vomiting related to coughing, then people get dehydrated, especially kids get dehydrated due to this excessive vomiting, due to the excessive coughing. Then there is laryngotracheitis. So if there is tracheal inflammation or basic airways trachea, if you go below the larynx, there is basic air pipe called trachea. So if there is infection of the larynx as well as trachea, it's called laryngotracheitis. There might be dehydration as well because of excessive respiratory rate and loss of water vapors through excessive respiratory rate. And then there is febrile illness. Patient is um, uh, getting weak day by day due to this febrile illness. There is hypoxemia as well. Hypoxemia means low level of oxygen in our blood due to uh, uh, deranged oxygen diffusion at the alveolar levels in our lungs. We are not able to extract the oxygen or use the oxygen from the air and move into our blood because our lungs have become faulty. That's resulting in hypoxemia. Clinical signs and symptoms of viral respiratory infection in elderly are also important. Emergency warning signs in adults can include the following, such as difficulty breathing, persistent pain or pressure in the chest or abdomen. There is persistent dizziness, confusion, or inability to arouse. There are seizures, not urinating. So, if the person is not urinating, it means there is renal damage as well. Severe muscular pains, severe weakness or unsteadiness. Patient is unable to walk properly. Patient is having unsteady gaze. There is severe weakness, fever or cough that improve but then return or worsen. Fever, cough, sinusitis, otology or rhinorrhea, respiratory failure, dyspnea, hoarseness, headache, wheezing, cough. So all of these symptoms are present in elderly people. But if the elderly people are not urinating or having seizures, then there is a problem. You need to get them admitted in a intensive care unit or intensive care facility because these kind of symptoms are very, very dangerous symptoms, and it means that the infection has spread and it is damaging whole of their body. Emergency warning signs of respiratory virus complication in children are fast breathing or trouble breathing, bluish lips or face, ribs that pull in with each breath. If you see a child who is pulling his ribs inside with each breath and there is labored breathing, then there is a problem. If the child tells you that he is or she is having chest pain, if there are severe muscular pains, for example, child even refuses to walk with some viral respiratory infections. If there is dehydration, for example, no urination for 8 hours, if there is dry mouth or no tears when crying, then there is a red flag sign and if you immediately need to go to hospital. If there are seizures, if there is fever above 104 degree Fahrenheit that is not getting controlled by antibiotic medications, and in children younger than 12 weeks, any fever above 100 1 degrees or 100 degree Fahrenheit warrants immediate checkup by a pediatrician. Fever or cough that improves but then returns or worsens, that is also a dangerous sign. It means that something that was improving has worsened. It also shows that there is some sort of secondary bacterial infection as well, because usually our body starts to fight viral respiratory infection, but if there is secondary bacterial infection, then the cough returns with more severity. So if you see a child who's breathing fast or who's having trouble breathing, whose face is getting blue or there are bluish lips, it means the child is hypoxemic. The child is not getting enough oxygen due to the lung damage. The ribs that pull in with each breath, it means the lungs are working hard enough to inhale as deep as possible due to air hunger. If there is chest pain, it means the problem has worsened. If the child refuses to walk, it means the muscle damage has started to occur. If there is dehydration, you need to rehydrate the patient. If there are seizures, it means nervous system is also getting involved. So all of these things are dangerous signs, and these are very, very important to remember, because if you see a child and you miss these things and you do not know these things, the child may die within a day or two of showing these signs. So you need to understand, you need to remember these emergency warning signs of respiratory virus complications in children, because children often succumb to upper respiratory or even lower respiratory tract infections because of lack of awareness of danger signs. So, diagnosing a patient with viral respiratory tract infections, the diagnosis is uh, part clinical and part molecular biological. So certain viruses can be identified based on their areas of infection or symptoms, such as rhinovirus most of the time causes rhinitis. So if you look at the anatomical location of viral syndromes, if you look at the picture on the right, then this is upper respiratory tract, which shows the nasal cavity, nasopharynx, oropharynx, and larynx. So basically, if a virus is infecting nasal cavity, then it most commonly is rhinovirus or coronavirus. And if a virus is infecting nasopharynx, oropharynx, or larynx, for example, if you are having a hoarseness of voice, if you are having sore throat, then it is not rhinovirus, because rhinitis is the major symptom of rhinovirus. And coronavirus also does not affect throat. It does affect the sense of smell. It does affect the sense of distinguishing different fragrances. But if there are throat symptoms, then you are getting infected with adenovirus or parainfluenza virus, not with rhinovirus or coronavirus. Similarly, if you come into the lower airways, if you look at the larynx and trachea, then there is laryngeotracheal bronchitis or croup, which is most commonly caused by parainfluenza virus. And if you come to the bronchial level or bronchi level, then parainfluenza, influenza, coronavirus as well. Then if you come to the bronchial level, then bronchiolitis is most commonly caused by respiratory syncytial virus, influenza virus, metapneumovirus, and adenovirus, but among all, respiratory syncytial virus causes the severe infection and most common infection. So, by looking at the clinical picture, you can make a guess that what kind of virus I am dealing with. If the patient is showing the signs and symptoms of lower respiratory tract infection with increased coughing and respiratory rate and all of these problems, then your hint should be some lower respiratory tract virus, such as parainfluenza virus, respiratory syncytial virus, or influenza virus. But if a child or a person is showing upper respiratory tract symptoms, then your mind should go towards rhinovirus or adenovirus, etc. After thorough clinical assessment, some of the following tests of viral detection can be performed in the patients. You take specimens such as nasopharyngeal aspirates, nasal washings, nasal swab tests, and lower respiratory tract samples as well. Then you handle these samples with care. sample storage, and repeated freeze and thaw reduce virus recovery. So you do not repeatedly freeze and thaw the samples. You immediately freeze them and then thaw them for once, and you are about to run the tests. Then there are cultures as well. Virus isolation can be done in many human cell lines, such as in HEP2, HELA, A549 cells. So see, these are special cell concentrates of human body which grow the viruses inside them. So viruses do not grow alone. That is their hallmark feature. They need some other living medium, some other living surface to remain viable. So that is why virus isolation via culture can only be done by using some other human cell lines as well. You just do not throw glucose into the solution, and you just do not throw breadcrumbs into the solution and you start seeing viruses. No, viral cultures always needs other human cell lines to grow. And this way, viruses can be isolated after they replicate in lab controlled human cell lines. Then there is rapid antigen detection methods as well, such as immunofluorescence of respiratory cells, enzyme immunoassays, membrane-based chromatographic tests. Point of care kits are also present for our emergency or primary care physicians, but there are advanced molecular methods as well, such as RT-PCR, which is conventional and real time as well. It is gold standard these days. So running a PCR test on any virus is a gold standard test these days. So if you have any kind of advanced molecular lab and you want to confirm which virus you are dealing with, and you have to run the PCR. So real-time PCR gives you a quantitative picture. It also gives you subtype detection as well. For example, whether you are dealing with influenza type A, B, C, or D, real-time PCR gives you quantitative assessment of the viral load as well as subtype detection as well. So real-time PCR, that is why it is a gold standard. Then there is another test called NASBA, which is non-PCR amplification, but it is also available. Then there is also some limited clinical use of serology as well, but serology testing, NASBA, and all of these things are not gold standard. If you really want to know which kind of virus you're dealing with, then gold standard is real-time PCR. So management of patients with viral infections, most of the time you just need supportive care. Human immunity works fine. Our immunity fights off the virus in a very efficient way. So treatment of viral respiratory tract infections primarily involves supportive care. You need to rest, you need to hydrate, and you need symptomatic relief. For example, if you're having high grade fever, you need to take anti-fever medication. If you are having severe body aches, chills, and rigors, you need to take rest, you need to take painkillers, and you need to take herbal remedies as well, because herbal remedies do help in fighting off viral infections. You take honey, you take dates, you take different types of green teas or black teas. There are cocktails of combinations of various herbs used all around the world to fight off viral infections, and they do work. Literally, they do work. They increase our immunity and help us fight off a viral infection in a balanced way. Most viral infections resolve on their own. For specific viruses such like influenza, antiviral medication may be prescribed, and in severe cases, hospitalization may be necessary. So supportive care is most of the time needed. What is supportive care? You need to give the person infected rest, because if the person who is infected with any kind of virus does not rest for 2 or 3 days, they are more prone to spread the virus in all of the community, and they also are more prone to develop severe disease with secondary bacterial infections as well, because our body needs rest to fight off the infection. If you are using your body in all of other cores instead of resting, then your body's attention that keeps diverting from the virus to other things. Hydration. Drink plenty of water or other fluids to stay hydrated and loosen the mucus of your lungs. Soothing symptoms, warm lemon and honey drinks can soothe a sore throat and cough, not for babies under 1 year old. Yeah, honey drinks are not recommended for babies under 1 year old. Otherwise, you can give warm lemon, honey drinks, herbal drinks as well for patients, especially after 1 year old, after they're 1 year old. Over-the-counter medications such as paracetamol, acetaminophen, called Tylenol, etc., can help manage fever and body aches as well. Then specific viral treatments are needed in high-risk groups. For example, if you are dealing with influenza or respiratory syncytial virus, then antiviral drugs can also be used. When to see a doctor? We already discussed the warning signs in elderly and warning sign in children. And if you see all of those warning signs, then you need to see a doctor. If there is worsening of symptoms, and we discussed what is worsening of symptoms. Seek medical attention if your breathing gets worse or if symptoms don't improve over time. If your patient belongs to high risk individual, for example, the person is elderly or the person is too young, consult a healthcare provider if you are at high risk of complications from respiratory illness, such as young children, older adults, or those with compromised immune systems. You can also take antiviral medications as well. Timely and important antiviral are necessary. If you are deciding to take antiviral medications to fight off the infections, then 2 to 3 days, within 2 to 3 days of having flu, you need to take viral medications, and within 5 to 7 days of having COVID-19 or coronavirus infection, you need to take antiviral medication. If you are having at high risk of severe illness, you need to take these medications seriously, but these are prescription only medications because they have very side effects as well. So you need to talk with your healthcare providers before getting any kind of antiviral medications. Then core prevention strategies from viral respiratory tract infections are very important to understand. These are our last slides. So you need to understand how to prevent these infections. Stay up to date with recommending immunization schedules. Talk to your doctor or trusted healthcare provider about what may be recommended for you and your family. Practice good hygiene, like washing your hands regularly and cleaning commonly touched surfaces such as your mobile phones, etc. Take steps for cleaner air as much as possible in places where people live and work. There should be laminar airflow. There should be ventilated indoor spaces, because if there is no ventilation, then the risk of spreading infections other people by infected individuals increases 2 to 3 folds. So that is why cleaner air, ventilated inside places are extremely important. When sick with respiratory illness, use precautions to prevent spread. Stay home, take rest, and away from other people, because if you keep wandering around in the environment, you will keep spreading the virus everywhere. Seek healthcare promptly for treatment if you have risk factors for severe illness. Treatment may help lower your risk of severe illness. And regional prevention strategies are extra measures you can choose that can further reduce your risk of respiratory illness. They can provide an extra layer of protection and can be especially important in certain settings or when illnesses are increasing in your community. Number one, additional prevention strategies is wearing mask, and wearing mask. If you are sick with any kind of respiratory tract infection, then you know that whenever you sneeze or cough or even you take forceful breath, then you are shedding virus into the environment. So you need to wear mask to stop spreading the virus to other people. Always wear mask. Even if you are not sick, but some other person is sick and you are forced to stay together, and if the sick person is not wearing mask, the healthy person can wear mask to save themselves, because wearing masks drastically reduces the chances of getting infection through respiratory droplets. Then physical distancing is also important whenever possible, and you also need to you can also run some tests whether you are dealing with some dangerous strain of virus or not. Covering your coughs and sneezes limits the spread of germs to protect others. Hand washing with soap removes germs from your hands, making them less likely to infect your respiratory symptom when you touch your eyes, nose, or mouth. If soap and water are not available, using a hand sanitizer with at least 60% alcohol can kill all of these germs. To remove germs and dirt on surfaces, use household cleaners that contain soap or detergent. Cover your mouth or nose with a tissue whenever you cough or sneeze. Throw used tissues in the trash. If you don't have a tissue, cough or sneeze into your elbow. If you don't have a tissue, always cough or sneeze into your elbow, not your hands, because your hands will touch every other surface. And when your hands touch other surfaces, and when some other person touch that surfaces and they touch their mouth unknowingly, they get infected. Learn and use proper hand washing techniques. Teach children to correct the correct way to wash their hands and how to cover their face with your elbow. Clean frequently touched surfaces such as countertops, handrails, and doorknobs regularly. Have a nice day. Thank you. So we come towards the questions. So any questions, please?
Thank you. We can allow 5 minutes of questions as we run out of time. So let's go with CC Jules.
Okay, go ahead.
Thank you very much. Very good presentation. So
Thank
I
you.
have I have
It took
two questions.
it took me 2 or 3 days.
Yeah,
It took me
I
two
have
or three
two.
days because I
Yeah,
had to work a lot to
yeah.
summarize the knowledge, the sea of knowledge, because I had to deliver a lot within an hour. Thank you so much for appreciation.
Okay, my first question is, what are the fundamental and genuine difference between RSV, respiratory syncytial virus, and CV,
Mhm.
coronavirus, since both seem to have the same process, contamination by respiratory way, symptom and pathology affecting the lung, chest, and throat, high people infection rate, even prevention through washing or using hydroalcohol on the hand. What is the fundamental difference or genuine difference between these two, RSV and CV, because they seem to have the same, the same infection process or the same features. And the second question is,
Okay,
can RSV contaminate person through the blood? Through the blood? That's all my questions. Thank you.
okay. It is very simple for an infectious disease specialist or a doctor who specializes in infectious diseases. It is very easy for us to differentiate clinically, but then we run tests as well. As we told, we run real-time PCR testing, but clinically, we immediately recognize whether the infectious virus is RSV or coronavirus. First of all, as you know, coronavirus causes a very mild disease in 99% of the kids. Coronavirus causes a very mild disease in 99% of the kids. Kids may have coronavirus and they might just have a runny nose for 2 to 3 days and they are okay on the fourth day. That was not the case with adults. But RSV kills a lot of children worldwide. So respiratory syncytial virus is notorious for having severe disease in children. But coronavirus is a piece of cake for children. There were only 1% deaths, or even less than 1% deaths from coronavirus in children. 99% of the people who died were older than 10 years of age. So the first and foremost thing is understanding the severity of the illness. You look at the child with severe disease, coronavirus is out of the question. It is some other, most probably RSV, parainfluenza, or influenza, whatever, but not coronavirus. Overall, there are only 1% chances of a child dying from coronavirus or having severe disease with coronavirus. So this is a clinical difference. This is the clinical difference. Then you can do real-time PCR testing by using nasopharyngeal swab or respiratory washings. You can send those respiratory washings to the lab for a real-time PCR, and they will tell you within a day that what kind of virus you're dealing with. But clinically, if there is a child with severe bronchiolitis or severe pneumonia, it's not coronavirus.